Hello, and welcome back to Primary Care Snapshots for the management of chronic kidney disease. I'm your host, Dr. Gregory Krol. This is the third in a series of 5 videos designed to address chronic kidney disease, or CKD, in the primary care setting. In this snapshot, we'll discuss key points related to medications that can contribute to kidney disease and those that may require adjustment in the presence of CKD. We will focus on some of the more common drugs seen in primary care. However, you should realize that this is not an exhaustive list. I encourage you to collaborate with your medical references, nephrologist, or pharmacist when there are questions related to possible drug effects, drug dosing adjustments, and drug interactions. Let's begin by describing drugs that can contribute to CKD. Probably non-steroidal anti-inflammatory drugs, NSAIDs, are the most commonly used drug class by your patients, in part because of their over-the-counter availability. It is imperative that you evaluate the use of NSAIDs by your patients with declining kidney function. Your patients will need close monitoring of kidney function and blood pressure when changing to therapies other than NSAIDs. Most of your patients will be unaware of the effects that NSAIDs have on their kidney function. Inquire about over-the-counter use of cimetidine and trimethoprim-containing agents, since these can cause increased creatinine and lead to a false decline in true kidney function. Interestingly, nicotine impairs renal blood flow and negatively impacts kidney function. This is another reason smokers must be encouraged to stop. Also, assess for illicit drug use, since cocaine, methamphetamine, and heroin use are linked to increased risk for sudden kidney failure. Recent or anticipated exposure to iodinated radiographic contrast medium is another factor that may adversely affect kidney function. Non-contrast CTs, MRIs, and ultrasound alternatives should be considered when appropriate. Other drug families that should be evaluated, dose adjusted, and potentially eliminated include various antibiotics such as aminoglycosides and sulfonamides. Caution must be used in the continued use of exenatide for your patients with diabetes and GFRs less than 30. The FDA revised prescribing information for exenatide in 2009 due to reports of renal insufficiency and acute renal failure. Even drugs such as angiotensin-converting enzyme inhibitors and angiotensin type 1 receptor blockers, ACEs and ARBs, which we think of as nephroprotective, can contribute to a decreased GFR. Mild reductions are acceptable, and discontinuation of ACEs and ARBs is typically not recommended. When in doubt regarding the significance of a reduced GFR greater than 25%, you may wish to consult a nephrologist. CKD complicates medication prescribing and managing drug effects. The treatment of anemia, hyperkalemia, and elevated phosphate levels are beyond the scope of this snapshot. However, several points should be made about diabetic kidney disease management. When CKD is present, diabetes management requires ongoing scrutiny and awareness for dose adjustments of many diabetic agents. Decreased renal elimination of metabolites of repligionide, glyburide, sitaglipin, and even insulin places patients with diabetes at greater risk for hypoglycemia. Gabapentin, which may be prescribed for many peripheral neuropathies, may also require a dose reduction to prevent low blood sugars. Drugs that should be used cautiously in the presence of diabetic kidney disease include pioglitazone, metformin, and combination drugs that include metformin if the GFR is less than 50 milliliters per minute per 1.73 meters squared. Use exenatide with caution if the GFR is less than 30 milliliters per minute, and the alpha-glucosidase inhibitors if the GFR is less than 25 milliliters per minute. Generally, a nephrology and possibly a pharmacy consult should be considered when the diagnosis of acute kidney injury, acute renal failure, or CKD has been made. Be with us next time, as our next snapshot will provide an expert consult with nephrologist Dr. Jerry Yee. I think you will find his advice very helpful in your practice.